Good evening. Am I audible and visible? If I'm audible and visible, can I get a confirmation on the live chat, please? So, this is Dr. Shanmugapriya. Good evening, Prince Davis. Thank you, Bose. Yeah, thank you, Prince. So if you're joining my session for the first time, this is Dr. Shanmugapriya. I'm professor and head of the Department of Biochemistry at Government Thoothukudi Medical College. And I'm your Unacademy educator for Biochemistry. And this will be a high yield session for both NEET PG aspirants and FMGE aspirants. And here I have chosen few MCQs from NEET PG previous year questions. And using those questions, we'll be discussing many facts and concepts. Okay, so that's an outline for today's session. And before we start the session, let me tell you a few facts about Unacademy's plans. So as I've always been saying that there is something called as NEET PG 2023 Achievers Batch. And in this batch, we will be discussing all topics. All 19 educators will be discussing all topics conceptually. And in addition to that, there is also a previous year question batch. There is an image-based question. We will also be discussing we will also be conducting multiple tests and discussing those MCQs. Grant tests are also included. And of course, we also have doubt clarification sessions. So this will be like a success formula for anybody who is aspiring to crack and get a good rank in the upcoming NEET PG 2023. Good evening, Shakti. In addition to the MBBS Prof 1 package that's already available, now we also have MBBS Prof 2 package, and that would include recorded content playlist. There is also live batch sessions and mnemonics by Dr. Nikita. And to enroll yourself for any of these batches, good evening, Drinkle. Great evening to you too, Daru. Good evening, Gokul. Good evening, all of you. Good evening, Sakshi. Hi, Tanveer. Nice to meet you all again. So to enroll yourself for any of these batches, you can use my code C Shanmugapriya. And this is the plan for MBBS Prof subscription for MBBS Prof 1, Prof 2 and Prof 3. For Prof 1, 1 month subscription would cost you 1,349. For Prof 2, it is 1,799, and Prof 3 again it is 1,349. Good evening, Rajdeep. Hi, Radhika. Good evening, all of you. So let's start discussing MCQs now. So this is a NEET PG 20. Most of the questions today that I've chosen are from NEET PG 2021. This is the first question for today. Which of the following vitamins should be supplemented in a person with cystathionin beta synthase deficiency? Hi Soumya, please start answering, all of you. Good evening, Swati Dalla. Please answer. Cystathionin beta synthase deficiency. All of you. Sakshi says it's vitamin B6. Very good. Others, Rai Arora also says vitamin. Very good. So all of you are right. The vitamin that needs to be supplemented in a person with cystathionin beta synthase deficiency would be vitamin B6. So first I want you to know that cystathionin beta synthase deficiency causes homocystinuria. And why are you worried about homocystinuria? Because it presents with accelerated atherosclerosis. It presents with accelerated thrombosis. So if you see a patient, young patient presenting with myocardial infarction, young patient presenting with stroke, additionally you also see skeletal deformities like flat foot, Charlie Chaplin gait and ectopia lentis. What should you suspect? You should suspect homocystinuria, and you should estimate homocysteine levels. And then to treat homocystinuria, you will have to know whether it is type 1 homocystinuria or type 2 homocystinuria. And to understand all about these homocysteinurias, first is you will have to know the normal metabolism of homocysteine. Yes, it induces atherosclerosis. Excellent. So let's try to understand the normal metabolism of homocysteine. In another 5 minutes, you will be able to clearly delineate type 1 homocystinuria from type 2 homocystinuria, both in terms of diagnosis and management. Because homocysteine is a sulfur containing amino acid, homocysteine can get converted to one or the other sulfur containing amino acid. So what are the other two sulfur containing amino acids? One is cysteine, the other one is methionine. So what are the two fates of homocysteine? It can either become cysteine or it becomes methionine. How does homocysteine become cysteine? It's very simple. Homocysteine reacts with serine. Yeah, it reacts with serine in the presence of cystathionin beta synthase. The question is about this enzyme. And this cystathionin beta synthase is a B6 dependent enzyme and it gets converted to cystathionin. This cystathionin in the presence of cystathioninase becomes cysteine. So how does homocysteine become cysteine? Very simple. Homocysteine reacts with serine in the presence of cystathionin beta synthase to form cystathionin. That is B6 dependent, that then becomes cysteine. Now how will homocysteine become methionine? Logically, what should be the enzyme? The enzyme should be methionine synthase. And this methionine synthase is dependent on B12. Which form of B12 do you want for this? It is methyl B12. All of you please remember that there are two coenzyme forms of B12. One is methyl B12, the other one is adenosyl B12. Here we use methyl B12 which converts homocysteine to methionine. From where do we get this methyl group for methyl B12? That is from methyl tetrahydrofolate. So are you clear about these forms of homocysteine fates? So this is about homocysteine fates. What are the two fates of homocysteine? It can either become cysteine or methionine. For it to become cysteine, the enzyme that you want is cystathionin beta synthase, which is B6 dependent. For it to become methionine, you want methionine synthase, and that is dependent on B12 and folate. Now what are the causes of homocystinuria? Homocystinuria can be caused by either a defect of the major fate, this is the major fate, or because of the defect of the minor fate. If it is caused by the defect of the major fate, that is called as type 1 homocystinuria. So all of you please memorize, type 1 homocystinuria is caused by the defect of cystathionin beta synthase. If it is because of methionine synthase defect, you call it as type 2 homocystinuria. How will you find out whether it is type 1 or type 2? In type 1, which is cystathionin beta synthase defect, if this enzyme is defective, tell me what will happen to cysteine levels. Cysteine level will be low. And the defect is here, so the accumulated homocysteine will get converted to methionine. So what will you find? You will find low cysteine and high methionine. Do you all understand this? You find low cysteine and high methionine in type 1 homocystinuria. If it's type 2 homocystinuria, what will happen to methionine levels? It is methionine synthase defect, so there will be low methionine and high cysteine. So the only way of you differentiating whether it is type 1 homocystinuria or type 2 homocystinuria is by estimating cysteine levels and methionine levels. Do you all understand this? Kindly reduce thickness of the font. This is okay. So if it is type 1 homocystinuria, there is low cysteine and high methionine. In type 2 homocystinuria, there is low methionine and high cysteine. Why should you find out whether it is type 1 or type 2? Type 1 responds to B6 administration. Do you all understand this? Type 1 responds to B6 administration, whereas type 2 responds to B12 and folate administration. So this is how you differentiate type 1 and type 2 homocystinuria. So in this slide, I am going to write down all key facts about type 1 and type 2 homocystinuria. All of you try answering this. First, tell me which enzyme defect causes type 1. This recap is for your benefit. Please answer this. Type 1 is caused by the defect of which enzyme? It is caused by the defect of cystathionin beta synthase. Type 2 is caused by the defect of which enzyme? Methionine synthase. That is the first difference. What is the second difference? In type 1, which level will be low? In type 1, there is low cysteine levels, whereas there is high methionine levels. One second. In type 1, there is low cysteine levels and high methionine levels, and the reverse is found in type 2. In type 2, there is low methionine and high cysteine. Okay. The last difference is type 1 responds to B6 administration and type 2 responds to B12 and folate administration. Got it? So tell me, cystathione beta synthase deficiency responds to which vitamin? It responds to B6 vitamin. Okay. A person had his meal. This is the next question for today. This is also a NEET PG 2021 question. A person had his meal at 8 p.m. and records plasma glucose at 7 a.m. the next day. What is a major source of plasma glucose? What is the right answer? Drinkle says it's C. Is your answer C for the previous question or for this question, Drinkle? All of you start answering. Yeah, what is the answer here? The answer here is liver glycogenolysis. Excellent. Gokul, very good. Akshata, very good. Shivasai, very good. Paul. Yes, the answer is liver glycogenolysis. So let's try to understand what happens in starvation. Okay, if you try to understand the sequential changes that happen in starvation, you'll be able to answer such questions. Okay, so 8 p.m. the person has had his meal and 7 a.m. it is plasma glucose value is estimated. So it is 11 hours. At around 11 hours, what is the major source of plasma glucose? Answer is liver glycogenolysis. Okay. So about starvation, I want you to know that starvation is not equivalent to, for previous question, I understand, Wrinkle. Okay. So for what is starvation equivalent to? Starvation is never equivalent to energy deficiency. It is equivalent to fuel deficiency. Because starvation means the person has not taken food for a long time. What does food provide you with? A mixed balanced diet will provide you with all three fuels. What are the three fuels that you get from any diet? You get glucose, you get fatty acid, you get amino acid. So if you have not taken food for a long time, that is glucose deficiency, fatty acid deficiency and amino acid deficiency. Though all three fuels are deficient, you're more worried about which deficiency? You're more worried about glucose deficiency because the principal cells of your body, what are the principal cells of your body? Neurons and RBCs are dependent predominantly on glucose. So whenever you are starving, your body forgets about everything else. It has got only one aim now, that is to maintain plasma glucose. Yeah, whenever you are, yes, very good. Whenever you are in starvation, what is the only aim? Your aim is to only maintain plasma glucose. And to maintain plasma glucose, there are two pathways that we have. One is liver glycogenolysis, the other one is gluconeogenesis. And many have a doubt about glycogenolysis. You know, glycogenolysis happens in liver and in muscle. But only liver glycogenolysis can increase blood glucose. Muscle glycogenolysis can never increase blood glucose. It is because the product of glycogenolysis is glucose 1-phosphate. And if at all this glucose 1-phosphate should be able to reach the plasma, it should become glucose. For which, what is the enzyme you want? You want glucose 6-phosphatase. And this glucose 6-phosphatase, being an enzyme of gluconeogenesis, is present only in liver. It is absent in muscle. Don't we know that? What are the gluconeogenic organs, all of you? The two gluconeogenic organs are liver and kidney. Muscle does not perform gluconeogenesis because muscle lacks glucose 6-phosphatase. When it does not have glucose 6-phosphatase, not only gluconeogenesis, even glycogenolysis cannot increase plasma glucose because a product of glycogenolysis is not free glucose, but it is only glucose 1-phosphate. So we have ruled out muscle glycogenolysis being a source of plasma glucose. What is the source of plasma glucose? It is liver glycogenolysis, and then it is gluconeogenesis. And liver glycogenolysis begins 6 hours, liver glycogenolysis begins 2.5 hours after the previous meal. Suppose you have your lunch, yeah, you have your lunch by around 1 o'clock, 1 p.m. till 3 to 3:30. From 1 p.m. till 3 to 3:30, your dietary glucose will maintain plasma glucose. After which contribution from dietary glucose to maintain plasma glucose decreases. So what comes for the rescue first? It is liver glycogenolysis, which is initiated first. It begins 2.5 hours after the previous meal. And do you think it can go on forever? No, because at one point all liver glycogen will get used up. So liver glycogenolysis can maintain blood glucose till 12 to 18 hours of starvation. It almost ends till 12 hours, but it can extend till 18 hours depending upon the liver glycogen content. So at this point, I want you to understand that till 12 hours of starvation in everybody, what will be the major source of plasma glucose? It will be liver glycogenolysis, and then it is taken over by gluconeogenesis. And as far as gluconeogenesis is concerned, you will not be waiting for the last molecule of glycogen to get used up, and then you will not switch over to gluconeogenesis. There will be an overlap. So gluconeogenesis begins 6 hours after the previous meal. Though it begins 6 hours after the previous meal, till 12 hours, which is the major source of plasma glucose? It is liver glycogenolysis. Are you clear about this? Yeah. So tell me, what is the right answer for this question? It's only 11 hours after the previous meal. Till 12 hours, what will be the major source of plasma glucose? It is liver glycogenolysis. We know muscle glycogenolysis cannot be a source of plasma glucose anytime. Gluconeogenesis becomes a source of plasma glucose after 12 hours, and dietary glucose only till 2 to 2.5 hours of the previous meal. Okay. Yes. So this is another question which is repeatedly asked, right? Many questions are asked about DNA repair mechanism. So I'm going to use this question to help you understand about DNA repair mechanisms and about defects of DNA repair. So please watch this. A young patient presents with colon cancer. Whenever a young patient presents with colon cancer, we suspect Lynch syndrome. What is Lynch syndrome? It is nothing but hereditary non-polyposis colon cancer. The most common DNA repair mechanism defect causative of this condition is, what causes hereditary non-polyposis colon cancer? I'll help you memorize it. Colon cancer has got 2C. It is caused by the defect of 2M. Yeah, what is 2M? Mismatch repair defect. Have you all understand this? It is mismatch repair defect. Yes. So answer is choice C. Let's use this opportunity to learn about all DNA repair mechanisms and defects of DNA repair. There are 4 mechanisms of DNA repair. The first one is nucleotide excision repair. Yeah, so actually the first one is base excision repair. Okay, the first one is base excision repair. The second one is mismatch repair. The third one is nucleotide excision repair. The last one is double-stranded DNA break repair mechanism. So these are the 4 names that you should memorize. So first, about what is base excision error. Base excision error means the backbone of the DNA is maintained properly and only the base gets lost. You know, this is how the DNA is arranged, right? So what do you mean by base excision? It means the backbone is maintained properly. Only what is lost? Only the base gets lost. And okay, this is the most common error that can happen in a DNA. This can be asked as a simple factual MCQ. They can ask you which is the most common error that happens in a DNA. What should be your answer? Your answer should be base excision. And then about mismatch repair, tell me defect. What is mismatch error? Mismatch error is if there is A. Yeah, if there is A on one strand, you expect T to be on the other strand. Instead of there being T, if there is G or C, that is called as mismatch error. And a defect of mismatch repair causes, MM defect causes CC. What is CC? Hereditary non-polyposis colon cancer. Okay. And then nucleotide excision repair. In nucleotide excision repair, do you see an X? You see an X, right? So nucleotide excision repair defect causes X xeroderma pigmentosa. Yeah, it causes xeroderma pigmentosa. So I want you to remember one basic fact. UV light, yeah, UV light has got a propensity to cause pyrimidine-pyrimidine dimerization. So adjacent pyrimidines undergo dimerization in the presence of UV light. Whenever such dimers are formed, the repair mechanism is done by nucleotide excision mechanism. And a defect of nucleotide excision repair causes xeroderma pigmentosa. Yes, it is characterized by hypersensitivity to UV light and increased propensity to develop skin malignancies. Okay. Now, double-stranded DNA break repair defect causes ABF disorders. The mnemonic that you can have is ABF. So, what does ABF stand for? A stands for ataxia telangiectasia, B stands for Bloom syndrome, and F stands for Fanconi's anemia. Okay, so can we repeat all that we have discussed so far? Please repeat it along with me. Which is the most common error that can happen in a DNA? The most common error is base excision error. And a defect of mismatch repair causes MM. Repair defect causes CC, hereditary non-polyposis colon cancer. And the nucleotide excision repair has got X. Defect causes X xeroderma pigmentosa. And then double-stranded DNA break repair defect causes ABF. What does ABF stand for? Ataxia telangiectasia, Bloom syndrome, and Fanconi's anemia. Good. So what is the answer here? The answer here is mismatch repair. A 35-year-old man on maize-based diet presents with diarrhea, dermatitis, and dementia. Which vitamin deficiency is the cause? What is that you know about diarrhea, dermatitis, and dementia? 3 Ds of pellagra. Yes, 3 Ds of pellagra. Pellagra deficiency is caused by niacin deficiency. So we now know that the answer for this question is niacin, but niacin is a favorite topic of all competitive exams. They keep asking you questions more and more on niacin. And you have to know in detail about the causes of niacin deficiency. So I want you to stay with me for another 5 minutes. Yeah, if you stay with me for another 5 minutes, yes, I will be telling you many facts now. But if you are alert and awake, and if you memorize the facts that I am going to tell you now, you will never forget the causes of niacin deficiency or the causes of pellagra. Okay, so for you to understand causes of pellagra, you will have to know how niacin is synthesized. Do you know that tryptophan is the precursor of niacin? Yeah, tryptophan is the precursor of niacin. Yes, Castle's necklace picture. Very good, Gokul. Yes, Castle's necklace picture is the same NEET PG 2021. Apart from this question on niacin, there was also an image-based question wherein Castle's necklace was shown and they asked you which vitamin deficiency causes this. Okay. So 60 milligram of tryptophan is equivalent to 1 milligram of niacin. Now I am going to tell you the steps involved in the conversion of tryptophan to niacin. Okay. Yes. So the first step of tryptophan conversion to niacin is tryptophan is acted upon by tryptophan pyrrolase and it gets converted to formylkynurenine. It becomes formylkynurenine. The next step is formyltransferase. I want you to convert this formylkynurenine to kynurenine. Okay, so how will you convert formylkynurenine to kynurenine? That is done by formyltransferase. And this formyltransferase transfers the formyl group to tetrahydrofolate, converting tetrahydrofolate to formyl tetrahydrofolate. The next enzyme is hydroxylase, which converts kynurenine to 3-hydroxykynurenine. Now comes an important enzyme, kynurenase. So this kynurenase converts 3-hydroxykynurenine to 3-hydroxyantranilic acid. Okay, it converts it to 3-hydroxyantranilic acid. And this kynurenase is B6 dependent. Please memorize it. Which enzyme is dependent on B6? Kynurenase is dependent on pyridoxal phosphate and that forms 3-hydroxyantranilic acid. And this 3-hydroxyantranilic acid goes through a series of a non-enzyme catalyzed chemical reactions, good for us, yeah, to become a ring called as quinolinate. And this quinolinate, whenever a ring gets attached to ribose 5-phosphate, you get a nucleotide. If you want niacin, yeah, it is niacin mononucleotide or niacin adenine dinucleotide. If you want a nucleotide to this ring, you should attach ribose 5-phosphate. So the enzyme is quinolinate phosphoribosyltransferase, transferase, which converts quinolinate to niacin mononucleotide. This niacin mononucleotide then becomes niacin adenine dinucleotide. A kinase converts it into NADP. Okay. So have you understood this? Yeah, this is an outline of conversion of tryptophan to niacin. If you understand this outline, you will understand the causes of pellagra. So tell me, what are the causes of pellagra? Causes of pellagra will be niacin deficiency, obviously in the diet, dietary niacin deficiency, or it can be deficiency of tryptophan. So when do you expect deficiency of tryptophan? Whenever there is maize based diet. So maize has got tryptophan, but bioavailability of tryptophan from maize is very low. So if a person is on a maize based diet, yeah, farmers cultivate many crops, but what do they consume? They always try to consume something which is less costlier. So what do they store for themselves? They store for themselves maize. So set of farmers who are on maize based diet, they're more prone for niacin deficiency or pellagra, because bioavailability of tryptophan from maize is very less. Okay, and even if the diet has got tryptophan, what if there is tryptophan malabsorption? What do you call tryptophan malabsorption as? That is called as Hartnupp's disease. Okay, so Hartnupp's disease is caused by the defect of tryptophan absorption, and that will cause pellagra. Okay, and even if tryptophan is absorbed properly, what if tryptophan is used for something else? And if tryptophan is not used for niacin synthesis, what is the other biologically important product that you get from tryptophan? It is serotonin. What is serotonin? Serotonin is 5-hydroxytryptamine. You know that, right? Serotonin is 5-hydroxytryptamine, which you get from tryptophan. So what happens in carcinoid syndrome? Whenever a person suffers from carcinoid syndrome, most of the tryptophan will be used for serotonin synthesis. So tryptophan is not available for niacin synthesis. So carcinoid syndrome is also a cause of niacin deficiency or pellagra. Everything is perfect. There is tryptophan in the diet. Tryptophan has been absorbed, and tryptophan is also used for niacin synthesis, not used for anything else. But what if there is B6 deficiency? I said B6 or pyridoxal phosphate is necessary for kynureninase activity. So whenever there is B6 deficiency, tryptophan cannot be used for niacin synthesis. So that also causes pellagra. So what is the take home message for all of you? The take home message for all of you is pellagra is not only caused by niacin deficiency, it is also caused by B6 deficiency, because kynureninase, an enzyme that is necessary for the conversion of tryptophan to niacin, is dependent on B6. Okay, so B6 deficiency is a cause of pellagra. Now everything is perfect if a person is on a leucine rich diet. Yeah, sorghum, like maize, sorghum can also be a staple diet for a set of farmers. Again, sorghum is very less economically, it is very favorable for a farmer to consume sorghum. So sorghum based diet, sorghum is rich in leucine. So leucine is a branch chain amino acid which inhibits quinolinate phosphoribosal transferase. Leucine, a branch chain amino acid, inhibits quinolinate phosphoribosal transferase. That also causes pellagra, and that is called as leucine pellagra. So can you all tell me what are the causes of pellagra? Now it's easy, right? I'm going to write down all the causes of pellagra. Causes of pellagra, number 1 will be niacin deficiency in the diet, or it is tryptophan deficiency in the diet. Example, maize based diet, bioavailability of tryptophan from maize is very less. Now tryptophan is there in the diet, but what if there is tryptophan malabsorption? What is the other name for tryptophan malabsorption? It is Hartnupp's disease. So Hartnupp's disease, what will be the presentation? The presentation will be 3 Ds of pellagra, because it is tryptophan malabsorption. Niacin cannot be synthesized. Tryptophan has been absorbed, but tryptophan is used for something else. What can you use tryptophan for? Serotonin synthesis. So carcinoid syndrome is also a cause of pellagra. Now tryptophan is used for niacin synthesis, but there is B6 deficiency. So whenever there is B6 deficiency, kynureninase will be inactive. So tryptophan cannot be converted to niacin. Okay. And then leucine pellagra. What is leucine pellagra? Sorghum based diet. So whenever a person consumes sorghum as a staple diet, sorghum is very rich in leucine. Leucine inhibits quinolinate phosphoribosyl transferase, and that causes leucine pellagra. Got it? Yes. So these are the causes of pellagra. Okay, I've told you all these causes. So tell me, what is the right answer here? 35-year-old man on a maize-based diet is presenting with 3 Ds of pellagra, and it is because of the deficiency of which vitamin? It is because of the deficiency of niacin. It can also be caused by another vitamin deficiency. Which vitamin deficiency is it? It is B6. Okay, good. A patient with multiple tendon xanthomas. Yeah, whenever you see the term tendon xanthomas, please remember it is a feature of hypercholesterolemia. Okay, has a serum cholesterol of 400 milligram per deciliter. As expected, cholesterol level is high. You know, the normal cholesterol is less than 200 milligram per deciliter. So here it is hypercholesterolemia. And LDL level is also elevated. What is the diagnosis, all of you? Very good. Excellent. So all of you have given the right answer. It is familial hypercholesterolemia caused by the defect of LDL receptor. So just think logically and tell me what will happen whenever LDL receptor is defective. LDL will not be cleared off from the circulation. So LDL stays back in the circulation and LDL carries cholesterol. So that presents as familial hypercholesterolemia. Okay, so can we use this opportunity? Yeah, before we get into a detailed learning about hypercholesterolemia, I want you to know about other choices. What is choice A? Choice A is lipoprotein lipase deficiency, which is type 1. Yeah, it is type 1 hyperlipoproteinemia, wherein the enzyme that is defective is lipoprotein lipase, and here there will be an elevation of triglyceride. It will not present as an elevation of cholesterol. Type 1 will present as an elevation of triglyceride. So this is not choice A. What about Tangiers disease? What is the cause of Tangiers disease? This was asked recently, right? In the latest INI-CET, there was an image-based question wherein they gave you grayish orange tonsils. So orange tonsils, orange color tang juice. Yeah, orange color tang juice. So Tangiers disease is characterized by grayish orange tonsils. And this is caused by the defect of ABCA1. What is ABCA1? ATP binding cassette transporter 1 defect causes Tangiers disease, which is characterized by grayish orange tonsils, and HDL level will be very low. Hypo-alpha lipoproteinemia. Very good, Akshata. Very good, Dr. J. Very good, Rishabh. So this is not Tangiers disease, because Tangiers disease there is very low HDL and low cholesterol. Okay. And then LCAT deficiency. What is LCAT? It is lecithin cholesterol acyl transferase. And whenever there is LCAT deficiency, it presents as fish eye disease. What will it present as? It will present as fish eye disease, which is nothing but corneal haziness. Yeah, fish eye disease. There will be hemolytic anemia and chronic kidney disease. Do you find any of those features here? No. So the diagnosis here is straightforward. There is an isolated elevation of cholesterol, particularly an elevation of LDL. So what is it? It is familial hypercholesterolemia, which is type 2A. So can we start learning about, very good Akshata, I am very happy that you remember all these facts. So can we learn about hyperlipoproteinemias? Yeah, hyperlipoproteinemias, Fredrickson's classification. How many types do we have? Yeah, partial, yes, very good Dr. J. Partial LCAT deficiency will present as fish eye disease, wherein there is haziness of the cornea. Complete LCAT deficiency will also present with corneal haziness or fish eye. But apart from that, there will also be chronic kidney disease and hemolytic anemia. Yeah, hemolytic anemia, and both partial LCAT deficiency and complete LCAT deficiency is characterized by lipoprotein X. It is characterized by lipoprotein X. I remember it as LCAT. Yeah, C, right? If you put another C on the other side, what is it? It is lipoprotein X. Yeah, please remember it that way. LCAT deficiency is characterized by what? Lipoprotein X. Okay. and chronic kidney disease. So that's about LCAT deficiency because Dr. J had a question about it. Okay. So Fredrickson's classification, how many types do we have? So there are 6 types of hyperlipoproteinemias. What are the 6 types? 6 types would include type 1, type 2A, 2B, 3, 4 and 5. Yeah, type 1, 2A, 2B, 3, 4 and 5. So these are the 6 types of hyperlipoproteinemias. And for our understanding, for you to be able to make a diagnosis, for you to be able to make an understanding of the management of a patient, you should classify this Fredrickson's classification further into 3 categories. So what are the 3 categories? The first category presents with only an elevation of cholesterol. Second category presents with only an elevation of triglyceride. Third category presents with an elevation of both. Okay. Now which hyperlipoproteinemia presents with only an elevation of cholesterol? There is only one hyperlipoproteinemia which presents with only an elevation of cholesterol. Before we discuss that, what will be the clinical feature of hypercholesterolemia? Hypercholesterolemia is always present with tendon xanthomas and accelerated atherosclerosis. So if the history says, suppose you are given a case-based MCQ. Yeah, you're given a case-based MCQ where they provided you that there are tendon xanthomas, that is accelerated atherosclerosis. It means it's a clue that is given to you, that's an elevation of only cholesterol. And if you're asking me what are tendon xanthomas, these are small eruptive lesions which are present along the line of attachment of tendons. Can you see that here? Along the ankle. You know, ankle, there are multiple tendon ending, right? So along the ankle, along the wrist, yeah, and here along the ankle. So if you see xanthomas here, what are they? They are tendon xanthomas, which means there is an elevation of only cholesterol. Okay. If there is an elevation of triglyceride, they present with eruptive xanthomas. They present with eruptive xanthomas, recurrent pancreatitis, and on examination you find lipemia retinalis. So what are the findings whenever there is elevation of triglyceride? Whenever there is an elevation of triglyceride, you find eruptive xanthomas, recurrent pancreatitis. On examination, you find lipemia retinalis. If you're asking me what are eruptive xanthomas, these are even tinier than tendon xanthomas, and these eruptive xanthomas are present along the extensor surfaces of your limbs. Can you see that here? These are eruptive xanthomas. Of course, they might confuse you with phrenoderma. Yeah, phrenoderma distribution is also along the extensor surfaces of the limb. But how you can differentiate eruptive xanthomas from phrenoderma is, phrenoderma will have a keratin plug in the tip. Yeah, phrenoderma is follicular hyperkeratosis, when you will see a keratin plug in the tip, that you will be missing in eruptive xanthomas. So these are eruptive xanthomas, which means there is an elevation of TGL. Okay, and if it's a condition wherein there is an elevation of both cholesterol and triglyceride, you will find a mix-up of both these features. Okay, now which hyperlipoproteinemia presents with an elevation of only cholesterol? That is only one hyperlipoproteinemia, which is type 2A. Yeah, only type 2A presents with an elevation of cholesterol. That is why type 2A is otherwise called as familial hypercholesterolemia. And this is caused by the defect of LDL receptor. And whenever there is LDL receptor, yes, phrenoderma is a feature of vitamin A deficiency. Good. There is another question on vitamin A deficiency now. I will tell you about that. Okay. So LDL receptor defect will present is nothing but familial hypercholesterolemia, and what will it present as? It will present as tendon xanthomas and accelerated atherosclerosis. And the one fact that I want you to remember about type 2A of familial hypercholesterolemia is that it is an autosomal dominant condition. What is it? It's an autosomal dominant condition with gene dose effect. It's an autosomal dominant condition with gene dose effect. And if they ask you what are the autosomal dominant hyperlipoproteinemias, your answer should be type 2A, type 4 and type 5. Yeah, what are the autosomal dominant hyperlipoproteinemias? Type 2A, type 4 and type 5. Okay. So, have you understood this question? Yeah, in this condition, there is an elevation of only cholesterol with an elevation of LDL. So what is your answer? Your answer should be familial hypercholesterolemia. Okay. Answer is choice B. So this was answered by few of you already, right? Many of you were answering it as vitamin A when I told you about phrenoderma. So this is also a NEET PG 2021 question. This child also presented with night blindness and presented with Bitot spots. So night blindness and Bitot spots means it is vitamin A deficiency. And this image was also provided and they asked you what is the dermatological finding. Yes, we know the answer already. It is phrenoderma. Now to understand why should vitamin A deficiency present with phrenoderma, let me tell you about the various forms of vitamin A. Okay, so there are 3 forms of vitamin A. Let's quickly revise all about vitamin A. So what are the 3 forms of vitamin A? The first one is the alcohol form retinol, OL, and then the aldehyde form retinal, AL, and finally the acid form retinoic acid. So the 3 forms of vitamin A will be retinol, retinal and retinoic acid. And retinol, what is the significance of retinol? This is the form in which vitamin A is absorbed. This is the form in which vitamin A is transported and stored. This was asked in NEET PG. In which form is vitamin A stored? Vitamin A is stored in the form of retinol, the alcohol form. And then the aldehyde form retinal. In retinal, do you see retina? In the name retinal, do you see retina? Yes, right? So that is a clue that is given to you that this is the one that is present in the eye. It is present in rods and cones. I am very sure that you know in both rods and cones there is rhodopsin and conopsin. And what is rhodopsin? Until rhodopsin is stimulated by light, rhodopsin is nothing but 11-cis retinal in the center. Yeah, rhodopsin is nothing but 11-cis retinal in the center that is surrounded by opsin. So what is rhodopsin, all of you? Rhodopsin is nothing but 11-cis retinal in the center plus opsin. Now about retinoic acid, there are 2 forms of retinoic acid. One is all trans retinoic acid. The next one is 13-cis retinoic acid. And all trans retinoic acid helps in growth and differentiation of epithelium. There is 13-cis retinoic acid suppresses keratinization of epithelium. Please memorize it. 13-cis retinoic acid suppresses keratinization of epithelium. That is why what happens in vitamin A deficiency, 13-cis retinoic acid is deficient. So no suppression of keratinization, excess keratinization happens. And that causes follicular hyperkeratosis. What is follicular hyperkeratosis? It is phrenoderma. So if you see small papular lesions on the extensor surfaces of the limb with a keratin plug, you should know that it's follicular hyperkeratosis of phrenoderma, which is caused by vitamin A deficiency. Okay, and only because it suppresses keratinization of epithelium in vitamin A deficiency, there is excess keratinization of conjunctival epithelium which causes xerosis. And the keratin accumulates, yeah, the excess keratin that is formed will accumulate as Bitot spots. Have you understood all this? So that's about vitamin A various forms. So what is answer here? The answer here is phrenoderma. So this will be the last question for today. A 4-year-old boy presented with developmental delay, recurrent chest infections and worsening bone pain. His serum PTH was normal, parathormone is normal, calcium was normal and phosphate was low. Some students said that there was also a statement on no response to vitamin D. Yeah, no response to vitamin D administration was also a statement that was provided by few students. Few students said there was no such a statement. Irrespective of whether the statement is provided or not, you will be able to make a diagnosis. The probable diagnosis is vitamin D dependent rickets type 1, type 2, X-linked hypophosphatemic rickets and nutritional rickets. What is the right answer? The right answer is X-linked hypophosphatemic rickets. Why am I saying that this is the right answer? Just from one clue. The clue that I am looking for is what has happened to PTH level. If it is vitamin D deficiency, if it's vitamin D deficiency or vitamin D dependent rickets type 1 and type 2, in all these cases PTH level will be elevated. Whenever there is rickets due to vitamin D deficiency, be it nutritional rickets or vitamin D dependent rickets type 1 or type 2, in all these cases parathormone level will be elevated. We call it a secondary hyperparathyroidism. If PTH level is normal but you find all other features simulating rickets, then you should think of X-linked hypophosphatemic rickets. Okay. So first I will tell you why will you find high PTH level in rickets. For that you will have to know about regulation of vitamin D synthesis. So which is the rate limiting enzyme of vitamin D? So if you watch this session for another 2 to 3 minutes, you will understand exactly what is the biochemical feature of rickets, and you will also understand what is X-linked hypophosphatemic rickets. Okay. So about regulation of vitamin D synthesis, the rate limiting enzyme of vitamin D synthesis is 1-alpha hydroxylase. And we know that this 1-alpha hydroxylase converts 25 hydroxy vitamin D to 125 hydroxy vitamin D. I hope you all remember that vitamin D is synthesized by the action of UV light on 7-dehydrocholesterol, which is present in the skin. And this UV light opens up one of the rings of cholesterol and it converts 7-dehydrocholesterol to cholecalciferol. So from the skin, this cholecalciferol is released into the circulation and it reaches the liver. What happens in liver? In liver we have 25-alpha hydroxylase which converts cholecalciferol to 25-hydroxy vitamin D. Thanks, awesome doctor. I'm happy that you like this teaching. So this reaches kidney, and in kidney 1-alpha hydroxylase converts 25-hydroxy vitamin D to 125-dihydroxy vitamin D. And this 1-alpha hydroxylase is the rate limiting enzyme. Please remember, the first step 25-hydroxylase is present in liver. The next enzyme is present in kidney. This is the rate limiting enzyme. And this rate limiting enzyme is stimulated by parathormone. Please understand, stimulated by parathormone. And what is the effect of 125-dihydroxy vitamin D? For want of time, I'm not going to tell you exactly the actions of vitamin D. But ultimately put together, vitamin D effects would be to increase calcium and to increase phosphate. What does vitamin D do? It increases both serum calcium and serum phosphorus. So how do you think vitamin D synthesis has to be regulated? It has to be regulated based on calcium availability and phosphate availability. Okay. Whenever there is hyperphosphatemia, it directly inhibits 1-alpha hydroxylase, because once you have adequate phosphate, you don't want further 125-dihydroxy vitamin D to be synthesized. If you allow it to be synthesized more and more, that will end up in hyperphosphatemia. So whenever there is hyperphosphatemia, in a feedback mechanism, it inhibits 1-alpha hydroxylase. Okay. And whenever there is hypercalcemia, that should also inhibit 1-alpha hydroxylase, but it cannot do that directly. Of course, it can do that indirectly, because this hypercalcemia suppresses parathormone secretion. Don't we know this already? You must have learnt about this in medicine. You must have learnt about this in physiology, that your follicular cells in parathyroid gland have something called as calcium sensing receptor. And this calcium sensing receptor will keep sensing the blood calcium, and once you find the blood calcium to be adequate, this calcium sensing receptor suppresses parathormone release. Okay, because parathormone causes calcium increase. So hypercalcemia should also suppress 1-alpha hydroxylase. Can you explain why B6 preferring in auntie who suffers from, yes, I will tell you Daru. I will tell you. I can tell you definitely that. Okay. So hypercalcemia should also suppress 1-alpha hydroxylase activity. It cannot do that directly. It does that indirectly, because whenever there is hypercalcemia, it acts on the calcium sensing receptor of parathyroid follicular cells and it suppresses parathormone secretion. Once parathormone secretion is suppressed, 1-alpha hydroxylase activity is suppressed indirectly. Are you clear about this? This is how vitamin D synthesis is regulated. It's regulated at 1-alpha hydroxylase step, which is stimulated by parathormone. Okay. Now, what happens whenever there is vitamin D deficiency? Whenever there is vitamin D deficiency, tell me what is expected to happen to calcium level and phosphate level. No. INH Nandini. Nandini VP, it's not because of rifampicin, it is because of INH. Let me tell you that at the end. But for now, when there is vitamin deficiency, what will happen to blood calcium and blood phosphate? There is a decrease in the blood calcium and decrease in the phosphate levels. Okay. Now tell me what will happen when there is low calcium to parathormone secretion. Just now I told you hypercalcemia suppresses parathormone secretion. So hypocalcemia will stimulate parathormone secretion. That is why I told you whenever there is vitamin D deficiency, there is secondary hyperparathyroidism. Now what is the effect of secondary hyperparathyroidism? Do you all remember that parathormone increases calcium reabsorption in the distal convoluted tubule and it causes phosphate secretion. Yeah, what does parathormone? It causes calcium reabsorption, it causes phosphate secretion. So when there is secondary hyperparathyroidism, there is an increase in the calcium reabsorption and there is phosphate secretion. When there is increase in the calcium reabsorption, the hypocalcemia is treated. Yeah, the hypocalcemia is treated. That is why in vitamin D deficiency, calcium levels will be normal. Do you all understand this? Don't expect calcium levels to be low in vitamin D deficiency. Many a times in a patient with vitamin D deficiency, calcium levels will be at least near normal. How is it near normal? It is because of secondary hyperparathyroidism causing calcium reabsorption. But what will happen to phosphate level? Already the phosphate level is low and the secondary hyperparathyroidism is causing further phosphate secretion. So phosphate level will be very less. Do you understand this? Phosphate level will be very less. So can you tell me the biochemical features of vitamin D deficiency? Whenever there is vitamin D deficiency, calcium level will be near normal, but phosphate level will be very low because of secondary hyperparathyroidism. So PTH level will be elevated. Now do you understand why I said vitamin D deficiency always presents with an elevated PTH? So the elevation of PTH is because of secondary hyperparathyroidism. And whenever parathormone levels are elevated, ALP level, alkaline, bone alkaline phosphatase level will be high. So ALP level will also be high. Got it? So these are the features of vitamin D deficiency. So tell me what are the biochemical features of vitamin D deficiency? Whenever there is vitamin D deficiency, calcium level will be near normal. But phosphate level, this is not about hypophosphatemic rickets. I am telling you about vitamin D deficiency rickets. So whenever there is vitamin D deficiency rickets, calcium level will be near normal, but phosphate level will be low because of secondary hyperparathyroidism. So PTH level will be high. Whenever PTH level is high, ALP level will be high. Got it? Yes. So now what happens in X-linked hypophosphatemic rickets? In X-linked hypophosphatemic rickets, it's an X-linked dominant condition wherein there is a mutation of FEX gene. So that causes low levels of FEX protein. This increases FGF23 values. What does it elevate, all of you? In X-linked hypophosphatemic rickets, which is caused by the mutation of FEX gene and low FEX values, FEX levels, it increases fibroblast growth factor 23 values. Now, what are the two actions of FGF23? One action of FGF23 is that it causes phosphaturic effects. It causes phosphate secretion. Okay, it causes phosphate secretion. Next action of FGF23 is that it inhibits 1-alpha hydroxylase activity in the kidney. When 1-alpha hydroxylase activity is low, vitamin D levels, the active forms of vitamin D level will be low. And that causes rickets-like manifestations. Do you understand this? That causes rickets-like manifestation. So in X-linked hypophosphatemic rickets, there will be low phosphate, point number 1. Point number 2, when there is low 1-alpha hydroxylase activity, there is low active form of vitamin D. When there is low active form of vitamin D, there will be ricket-like manifestation. And this low calcium will stimulate parathormone. Of course, the low calcium will stimulate parathormone, but the hypophosphatemia will decrease parathormone. Ultimately, there will be normal PTH. Do you understand this? Ultimately, there will be normal PTH. So, how will you differentiate? Yeah, how will you differentiate X-linked hypophosphatemic rickets from the other forms of rickets? One is there is normal PTH in X-linked hypophosphatemic rickets, and the second feature is it does not respond to vitamin D supplementation. Got it? You're confused? Okay. Drinkle is confused, and for the benefit of Drinkle, I'm going to repeat this. Okay. So Drinkle, follow this closely. Let me tell you all about X-linked hypophosphatemic rickets. So point number 1 about hypophosphatemic rickets is its inheritance. What did I tell you about its inheritance? It is an X-linked dominant condition caused by the mutation of FEX gene. So FEX gene mutation causes reduced FEX levels, and reduced FEX levels will cause increased FGF23 values. Are you with me, Drinkle, till now? Yeah, it increases FGF23 values. Now there are two actions for FGF23. One action of FGF23 is that it has got a phosphaturic effect. It causes phosphate secretion in the renal tubule. So that causes low phosphate values. When there is hypophosphatemia, what will happen to parathormone secretion? Parathormone already causes phosphaturic effect. There is already something else which is causing phosphaturic effect. So what will happen to parathormone secretion? That will be low. Got it? Now, additionally, the effect of FGF23 is that it inhibits 1-alpha hydroxylase action. When 1-alpha hydroxylase activity is low, what will not be synthesized? 1,25 dihydroxy vitamin D, or the active form of vitamin D, cannot be synthesized. Without active form of vitamin D, there will be clinically rickets-like manifestation, and this low levels of vitamin D will cause low calcium. Low calcium might stimulate parathormone, but the low phosphate decreases parathormone. Put together, what will happen to parathormone levels? Parathormone level will be normal. Do you understand this? In all the other forms of vitamin D deficiency, parathormone level is elevated because of secondary hyperparathyroidism. But in this case, parathormone level is normal. And in all other forms of vitamin D, vitamin D deficiency, they respond to vitamin D administration. But X-linked hypophosphatemic rickets will not respond to vitamin D. Got it? So these are the two ways by which you can differentiate X-linked hypophosphatemic rickets. And then someone was asking me about, who asked it? Daru. Daru asked me to say about anti-tuberculosis treatment causing peripheral neuritis, right? I am able to study only 4 to 5 hours. Will it be enough to get a top 500 rank in 2023 NEET PG? Please give your piece of advice. Okay. So it's not about the number of hours that you spend in preparation. Of course, that also matters. But it's all about mindfulness. Yeah, even if you spend like 4 to 5 hours, if you are mindful, if you concentrate to the maximum, the topic that you read or the concept that you learn, and it should be a smart way of learning, awesome doctor. So when I say smart way of learning, it should always be a retrospective way of learning. You should definitely attempt as many grant tests as possible. You should work out every question that is given to you in a grant test. Okay, and work out all previous year questions and attend high yield sessions. Yeah, that should suffice. Okay, so don't worry about the number of hours that you put in. It is all about how you work. I had taken one special class of transport mechanism of physiology series. Can you please share that link in our Telegram group? Finding out the link is a bit difficult, Gokul. I will try to find out. Yeah, I'll try to find out and share it. Yes, be confident. Yeah, that makes a big difference. So somebody was asking about anti-tuberculosis treatment, right? Let me try to tell you that. So when a person is on ATT, INH, isoniazide is an aldehyde, okay? B6, pyridoxal is also an aldehyde. So usually pyridoxal and aldehyde should be converted to pyridoxal phosphate, and this is done by pyridoxal kinase. And when a person is on anti-tuberculosis treatment, isoniazide is also an aldehyde. So that becomes a competitive inhibitor of pyridoxal kinase. So what will not be synthesized? Pyridoxal phosphate cannot be synthesized, which is the active form of B6. And this active form of B6 deficiency is the reason for peripheral neuritis. Do you understand this? Yeah, because B6 is necessary for transamination reactions and it's necessary for decarboxylation reactions. So without transamination, decarboxylation reactions, neural nervous system gets affected. That causes neuritis. That is why they respond to B6 administration. Okay. So thank you all. That's all for today. Meet you all again tomorrow. Most probably by 6 o'clock, I will conduct part 4 of this Biochem Pearl series. Okay. So tomorrow also we'll be discussing more questions. I'm a working doctor, got only 3 to 4 months. Is that rapid revision PYQs enough to get good rank? Yes. Yes, Daru. It's definitely enough. Just do high yield revision. Yeah, keep doing high yield revision. Don't think revision means I have to finish the entire medical curriculum first and then I have to revise. Yeah, whatever you read now is a revision because you have already done a bit of reading when you did your undergraduation. So all that you do now is revision. So keep revising high yield topics and high yield concepts. And to know what are the high yield topics and what are the high yield concepts, you should do grant tests. Okay. Yeah. Thank you all. See you tomorrow.